from NIAID come and speak to us about risk communication, and we wanted to take the opportunity to have him brief you on Zika, the pandemic in progress, and to have Dr. Sylvain Aldighieri at my furthest left from the Pan American Health Organization, who is the incident manager for PAHO's response to Zika, brief you on the epidemiological update of where Zika is in the Americas today. So I think we should start with Dr. Fauci because he probably has to get back to Bethesda quickly. Go ahead.
Okay, so what I'd like to do, rather than give too much didactic, just make a few comments and leave a considerable amount of time for questions, which I believe would be more informative. But just in a brief summary, what I did just a few moments ago in my lecture which was entitled Zika, a Pandemic in Progress, was to give an outline of some of the background for Zika, which now, given all the publicity it's appropriately getting, people are starting to learn a lot about Zika. It's an infection that was unknown until 1947 when it was discovered in an animal, a monkey, in the Zika forest in Uganda. The first humans were infected in 1952, and it kind of stayed under the radar screen for decades without any noticeable outbreaks until the first recorded outbreak was in the Yap Islands in 2007, and then in 2013, French Polynesia. It kind of worked its way across the Pacific into South America, predominantly in Brazil, but many other South American, Latin American, Central American, Caribbean countries. I'm going to leave it to Dr. Aldighieri to talk a bit about that. I did in there, but I'll leave that for him to discuss right now. It is a disease that's relatively mild, and that's one of the real issues we have with communications. How do you communicate the danger and the threat of a disease that is fundamentally, historically mild? It's fever, rash, eye inflammation called conjunctivitis, arthralgias, and myalgias, very few mortalities. It has associated with it a post-syndrome Guillain-Barré, which we see with other viruses, which is an autoimmune neurological abnormality that tends, for the most part, to resolve despite the fact that it could be serious. But in general, it's a disease of which 80% of the people don't have any symptoms. The real issue, which has thrust it upon the attention and concern of the entire world, but certainly in the Americas, is the association of Zika infection in a pregnant woman with the danger of congenital abnormalities, predominantly microcephaly, in a variable percentage of babies born of Zika-infected mothers. We don't know what that percentage is, and as I mentioned in the room just across the hall, one of the things we have to deal with in communications is that although we know a lot about Zika, literally every week that goes by, we learn more and more. We don't know exactly what the percentage is of microcephaly. We don't know beyond microcephaly what the long-range effect on babies who might look like they were born normal, but might have other defects that are more subtle, hearing, vision, intellectual, and others. So there's a lot to be learned over this period of time. That's the general status of Zika as a disease. Much study to be done. Very quickly in the United States, we have in the United States a considerable number, over 400 travel-related cases. There thus far have been no local transmitted cases in the continental United States, although there have been over 600, close to 700 cases in Puerto Rico, with 65 pregnant women having been infected. The big question in the United States is, will we get local transmission? And my response to that is very likely we will, and it will likely and hopefully, and I use the word hopefully, be constrained in the same way as our local outbreaks of dengue and chikungunya, were essentially well contained. In Florida, we had dengue and chikungunya, and in Texas, we had dengue. And that was contained because we had good vector control, which, as I'm sure we'll get into in the discussion, and I'm sure Sylvain will say it also about what's going on in the PAHO states down in South America and the Caribbean. I'm not going to give you any detail about the research endeavor that we're doing, except to say that the thing that people are most interested in is the issue of a vaccine. We will be putting a vaccine into human study in September of 2016. We're working on it right now. That's a study on safety and whether it induces the kind of response that you predict would be protective. Don't confuse that with a vaccine that's ready to be used. This is the first testing of a vaccine in September. We'll probably know if it's safe by the beginning of 2017, and if it is, we'll engage in a very large efficacy study, likely in South America or in the Caribbean, and that should take anywhere from 1 to 3 years to prove that it works or does not work. So let me stop there and hand it over to Sylvain, and then we can talk about some questions after that.
Thank you, Dr. Fauci. Good afternoon to everyone. My objective today is to share with you an overview of the regional situation regarding the Zika outbreaks, regarding microcephaly and other birth defects, and regarding Guillain-Barré. The day of today, we have 37 countries and territories reporting Zika virus transmission in the Americas. If you compare to the report published last week, we have one new country, Peru, reporting autochthonous transmission, and one new territory in the Caribbean, the French territory of Saint Barthélemy, the island of Saint Barthélemy in the Caribbean. It's important to note that all countries which have reported detected dengue and or chikungunya viruses outbreaks during the last years, the last 15 years, are considered at risk for having outbreaks of Zika. It means that we are expecting outbreaks of Zika from Mesoamerica to Latin America, to the southern cone until the north of Argentina, and in the Caribbean. So it's a very large portion of the territory of the region, and using the as one of the criteria, including with climate, with altitude, the range of dissemination of the vector, the mosquito Aedes aegypti, we think that about 500 million people in the Americas are at risk to be infected by the Zika virus. They live in area where they are at risk. However, it will be very complex to assess, to gauge the outbreaks of Zika, because it's a mild disease, and in some laboratory, when we use a serology test, it cross-reacts with other viruses of the same family, the flavivirus family. So, being mild and cross-reacting in test, it will be complex to do the difference with dengue outbreak and chikungunya outbreak when they occur. Now, regarding microcephaly and other birth defects, it's important to note that 5 countries, as the day of today, have reported microcephaly in this region. Brazil, Colombia, Panama, Martinique, and the United States. Of course, most of the cases are located in Brazil, and most of these cases in Brazil in the northeast area of Brazil. We are also concerned with the temporal and spatial association of Zika virus outbreaks and the Guillain-Barré syndrome, which is a paralysis. And at this moment, we have 7 countries in the Americas reporting an increase in Guillain-Barré syndrome cases in a context of Zika outbreaks. And these countries are Brazil, Colombia, Dominican Republic, El Salvador, Honduras, Suriname, and Venezuela. We are monitoring the situation on a weekly basis, and all the information is published on our website. So, at short and medium term, we know that millions of Zika virus infections are expected in the region. To say that, as it's complex, as I told you, we use dengue experience, we use our chikungunya experience, previous outbreak in this region, including the chikungunya outbreak starting late 2013 in this region. However, even if we know that in short and medium term we expect this outbreak of Zika, the long-term outlook of the Zika virus in this region is uncertain. So I would stop here, and as Dr. Fauci would be ready to answer any of your concerns.
Okay, let's take questions. If you could identify yourself, please. We'll start there. Go ahead.
Yeah. So the mosquito that is the predominant mosquito that transmits Zika is called Aedes aegypti. Aedes aegypti. There is another mosquito that is capable of spreading Zika called Aedes albopictus. In the United States, the range of Aedes albopictus is greater, if you look at the maps, greater and occupies more states than Aedes aegypti. However, just because it is capable of spreading Zika doesn't mean that it will be a major player of Zika. And the reason we say that is that in countries in which you have both albopictus and Aedes aegypti, and there is Zika spread, overwhelmingly the dominant mosquito that spreads it is Aedes aegypti. And there's a number of reasons for that. Aedes aegypti is a much different mosquito. It bites in the day, at night. It goes indoors, outdoors. It's very difficult to eliminate. Only likes to bite humans. The albopictus and other mosquitoes, they get distracted. They bite animals. They bite a variety of other species. So when you have Zika and you have Aedes aegypti and Aedes albopictus, the chances are overwhelming that Aedes aegypti is going to be the major vector.
We had ABC.
How do you
I'm
feel?
sorry, they're asking me to speak into the mic. So we
Okay,
can hear.
sorry, just to follow up on that question. How do you feel about that? I mean, USA Today portrayed that as a lost cause in the fight on Zika, with the peculiarities in that type of mosquito vector.
Yeah. Just to be clear, I never said anything was a lost cause. Others
Well, some reports have stated
okay, but
that it's...
okay.
If you could tell me how you feel then
Okay,
about
sure.
those who are saying that it is a harder
Yeah.
uphill battle because of that
Yes.
that peculiarity.
No, it's a good question. Aedes aegypti is a very difficult mosquito to control and eliminate. That doesn't mean that it's impossible to have a significant impact on it, but it will require a very aggressive, concerted effort for the reasons that I very briefly outlined. Their ability to exist and stay in places that are difficult to eliminate mosquitoes. For example, they like to stay indoors as well as outdoors, which makes the spraying, the outdoor spraying, ineffective for those mosquitoes. So what one would have to do is to raise public awareness, have cooperation at the community level to get people as best as they possibly can, where they can, to eliminate and diminish standing water of any type, as well as to push and try and to utilize environmentally friendly larvicides and insecticides. Having said all of that, it's still going to be very, very difficult to do. Now, years ago in the 50s and the 60s, Brazil itself made a very aggressive attempt to eliminate the Aedes aegypti mosquito. They did it successfully, but they did it in a way that would be almost non-feasible today. Very heavy use of DDT, very aggressive use going into homes, essentially spraying in homes, cleaning up areas, things that I think the general public would not be amenable to accepting. So it can be done, but historically it was done in a way that might not be acceptable now. Having said all of that, it indeed is a difficult challenge. I don't think it's impossible to control them.
Go ahead.
Thank you. I'm Fabiola Ortiz. I'm a Brazilian journalist. I write for BBC Brazil. So you mentioned the first testing of a vaccine will be probably only safe to prove it, if it works or not, in human beings in 3 years' time. But isn't it too long for developing economies, especially in South America, to wait for a vaccine for
So,
3
well,
years?
okay, so you have a couple of questions buried in there. Okay, so when I say 1 to 3 years, let me amplify that a little. So if we start an efficacy study, let's say in January or February of 2017, the speed with which you prove or disprove that the vaccine works or does not work depends on two factors. One, just how good it is, how effective it is, and the rate of infection in the community. So if in the early part of 2017, we still have major outbreaks in South America and in the Caribbean, we may show that it's effective or not within a year. If the infections go way down, the way Ebola went way down in West Africa when we were trying to test the vaccine, it may take 3 years to show that it works or not. So that's what I mean when I say 1 to 3 years. That's the first part of your question. The second part of your question is, that's not really very good for the countries that are involved. And you're absolutely right, because the reality of the situation is that it is very difficult to rush the development of a vaccine, particularly in a situation where you want to make sure that you embark and put upon the population a safe vaccine, because safety is a very important effort. If you just say, I think I have a vaccine, I'm going to give it to everybody, there can be very deleterious effects of that, particularly since we know that with flaviviruses, often you have what's called enhancement of infection by immunological phenomenon. So you always got to be careful of safety when you deal with a vaccine.
Can I, follow up? So, in your opinion, how maternal risks and those implications in babies that are born with microcephaly may suffocate the public health services in Latin America? You know, are you concerned that those countries won't be able to give the correct treatment, won't have enough financial support to treat those moms and babies?
Well, I will give a very brief answer and then hand it over to Dr. Aldighieri, who is an expert in that region. I can say that there almost certainly will be a public health and economic burden if you have a lot of babies who are born with microcephaly and other congenital defects. The estimates of the lifetime cost of caring for a child with that kind of impairment ranges from $1 million to several $1 million.
Yes. Of course, we are concerned about the burden on the health services in this continent regarding the management of pregnancies at risk and babies born with some birth defect, and also the follow-up of these babies, because what we see now is like the tip of an iceberg, the baby with a microcephaly. You are Brazilian, and I think I've watched some of your investigations in Northeast Brazil. So we see it at this moment with babies, but we will have to do a very close follow-up of babies born from mothers with a previous history of rash and fever, confirmed or not with Zika virus, and also babies born during outbreaks, not presenting at the moment of the birth with external defects, I would say. So we would have to monitor the development, the psychological evolution of the babies, the learning skills of these babies during a long period, from 2 to 4 years and maybe more. So there is a long work to do in these most affected regions. Sí, por supuesto. Estamos preocupados.
We are concerned with the burden created by the Zika impact in pregnancies as well as in newborns, which means that the whole platform necessary to classify pregnancies at risk and children born with congenital malformations will need a lot of work. And it's also very important to not only deal with children that are born with visible defects like a microcephaly, but to follow them very closely when they're born during the outbreak periods in places where there is Zika transmission. Follow them very closely psychologically and developmentally to see how they are learning and how they're developing socially. And that's going to overburden the health systems for many years. Countries that started the active transmission of the virus, such as the northeast of Brazil and Colombia, reporting the first cases in October of 2015, as well as countries in Central America like El Salvador, who reported important outbreaks of Zika virus.
Dr. Fauci, how critical is the $1.9 billion President has requested from Congress for funding? How much do you need that money?
Well, as I've said many times at congressional hearings and briefings, this is absolutely essential. We cannot do the job that's necessary to be done in order to really address this very serious problem adequately. The President asked for $1.9 billion because we need $1.9 billion. So it really is critical, not only to the effort of the NIH, but the CDC and FDA and USAID and all the components of government that are involved.
Every day, every week we wait, is that affecting?
Well, what we've done, and this could be really destructive, is that when you don't have any money that's designated, you have to do it. You can't say, I'm going to wait and not do anything. We had to start our vaccine work. So what I did and what I had to do was to move money, hopefully temporarily, because it'll be very destructive to other public health issues, from other areas that I would have spent it, given whatever it was, malaria, tuberculosis, influenza, and move it to get the Zika effort started. That's the reason why we need to do two things. We need to get the Zika money to work with Zika, and we need to backfill the money that we diverted away from others to start the Zika effort.
Okay. Let me pass on a question that came via email from Don McNeil of the New York Times, who you both know. And he asks, should women living in areas with Zika circulation delay pregnancy if they can? Because you can't avoid mosquito bites 24 hours a day for 9 months. So I'll ask that to either and or both of you.
Well, Don has asked that question multiple times. It's a very serious question, but it's also a complicated issue. And I've never been known to waffle on any question, but I'm going to give you a somewhat of a complicated answer. And the answer is that the idea of when one gets pregnant is a very personal issue, that is a very complicated issue that is impacted by the circumstances where you live. So it's a straight question, but it's complicated by the fact that in those regions, many pregnancies are unintended. In fact, in some areas, the majority of pregnancies are unintended. Also, in many of these areas, birth control is not readily available to people who want to utilize birth control, and the ability to make decisions regarding your pregnancy is guided by laws and religion and a variety of other things. So the simple question of delaying pregnancy is really very complicated, and that's the reason why regional authorities have actually made statements. So although if you take the United States government, we don't come out with a statement like that. But we know that, for example, the Minister of Health of Puerto Rico has come out and made such a statement. We don't essentially contradict her and say you're making a wrong misstatement. For her and that country, I mean that territory at that time, that's something that she well thought out. So it's a complicated issue that I don't think you're going to get a very clear answer depending upon the circumstance that you're in.
Okay.
A follow-up on that
Any more
question?
questions from the room? Because we almost have to go. Let me ask him because you've already asked.
Hi, my name is Shalin Shah from the GW School of Public Health. My question is, with the upcoming 2016 Olympics coming and thousands of athletes descending into Brazil, what are some steps PAHO is taking to prevent Zika transmission, given its ability to spread sexually as opposed to dengue and chikungunya?
Sylvain, about the Olympics?
What steps
What are the countries doing to protect
what are the countries
against,
doing to protect against the inflow of people during the Olympics?
and the prevention of sexual transmission there?
During the meeting, the last hour, we have a very nice picture regarding travels from the south of the continent to the north. And these are, I think, 40 million people commuting from the south of the continent to the north of the continent, United States and Canada. So thinking that some measures would prevent the importation of people carrying the virus from the south to the north would be a dream. What we have to ensure is awareness. Person at risk, aware of their risk. Pregnant women at risk, who are at risk, aware that the virus is circulating in the south, in most of the countries in the south. It's Mesoamerica, Central America, Caribbean, Latin America, and even the southern cone during some seasons. And aware that they need to access a doctor to get an advice, to get a test, and to be offered option. This is the most important aspect in order to prevent people at risk, pregnant women.
Thank you.
Okay. We have one more question from John Cohen of Science Magazine for Dr. Fauci, a two-part question. He asks, are you planning to skip phase 2 testing, as with Ebola vaccine test? And is there a concern that by the time a vaccine is ready for efficacy testing, it will become complicated due to widespread herd immunity?
Okay, so the paradigm of phase 1, phase 2, phase 2B, phase 3 has really gotten blurred over the last decade with regard to vaccines related to HIV, Ebola, and now Zika. The study that we will initiate in the first quarter of 2017, following what hopefully will be a successful phase 1 trial for safety and immunogenicity, and that will be 80 people in that trial. 80 people. It's a small safety trial. If it looks safe and it induces a good immune response, we plan to do a study in the first quarter of 2017 in a country that has a very high rate of infection, and that'll get to John's second part of his question. But if we have a country or a region with a very high rate of infection, we will power the study with enough people, and we would likely call that a phase 2B, which isn't 10,000s of patients, but maybe several thousand of not patients, of volunteers. And we believe that if the infection rate is high enough in that phase 2B, that we might be able to get enough data to make a decision whether or not it works or it does not work. So that's the answer to John's first question. The second question is, am I concerned that by the time we get to 2017, that there will be enough infections that you won't have you'll have herd immunity and you'll have enough people who've already been infected that you won't have enough active infections to be able to prove that it works. That is a possibility, but if you look at the history of dengue in that region, dengue did not come and then disappear after 1 year. So I would think that although there is now a big explosion in Brazil and just starting to see it in Colombia, I think you're going to start to see other countries that are going to have that peak. So there's always the danger, and I hate to use the word danger because it's good for the people if they get herd immunity, but there's always the possibility that there will be enough infections that you won't be able to prove the vaccine is effective. But that's something you just have to deal with because that's a reality of the situation.
I'm getting the signal that we have to wrap it up, so we'll have time for one last question for either Dr. Aldighieri or Dr. Fauci. Please go ahead, if you can identify yourself.
Hi, yeah, my name is Camille Von Cannell, and I write for Climate Wire, and I'm hoping you could just go over, once again, the links between Zika and climate change, and then after that, what lessons this outbreak may have for future climate change-related or exacerbated diseases.
Yes, let me start off by saying I really don't want to put too much of a emphasis at all on the role of climate change and what's going on right now. We could well have had Zika the way we have it now without any impact from climate change. The reason the word climate change came up was I was asked a question that, do I think that since the range of mosquitoes at a certain elevation has now gone up, that they are able to survive at a higher elevation, could that be due to environmental warming? Could. And my response was, yes, that is entirely possible, that when you have warming of climate, that you would increase the range of which a mosquito can function. That good? Okay.
I'm sorry, we have one last one from Vice Media, from Kaylee Rogers, who asks whether we have a sense of the risk of microcephaly. If 10 pregnant women were all infected in the first trimester, how many of them would have microcephalic births?
We don't know. The answer is we don't know, and that's one of the reasons why, in a communication conference like this, it's important. What I always say, if you don't know the answer, don't make up an answer. I can tell you the data that we have, and the data is there is a cohort study from Brazil that was small, that did not wait until the babies were born, that were looking at 88 pregnant women, 72 of whom were infected with Zika, 16 of whom were not. They did Doppler sonograms on the fetuses during the pregnancy, and they found that in the women who were Zika infected, 29% of the fetuses had abnormalities by Doppler sonogram. They weren't born yet by Doppler sonogram, whereas 0% of the babies in the 16 uninfected mothers had it. So one might say that that's a possibility that it's as high as 29%. But the study is small, and you need a much larger cohort. Soon after that, another study came out, which was retrospectively looking at stored samples from women who may have been infected, and they came to the conclusion that it was 1%. So the data that you have now is between 1% and 29%. However, having said that, we, the Brazilians, the CDC, and a variety of others are doing what's called cohort studies. And there's one study in particular called the Zika in Pregnancy study, which is going to enroll thousands of pregnant women in South America, predominantly in Brazil. When we get the data from that study, we'll be able to answer the question of precisely what that percentage is. But today, in May of 2016, we don't know the answer.
Thank you very much, Dr. Fauci and Dr. Aldighieri. I think we'll stop here because Bill Hall is asking us to continue and go back to our meeting, and we appreciate your coming down. If any of you want to talk with Dr. Aldighieri separately, lo podemos arreglar.